Thank you, Dr. Nandi, for inviting me for this excellent instruction course, which is specially focused for the macular hole. And this is Dr. I'm thrilled to see those exciting video from Dr. Anirudh Maiti, and all those technique we do, and the success rate is best in more than 90% in the West hand. But even that remaining 10% is still remaining. So the end is not blocked at that point of time. So if you fail after doing this conventional surgery, so what are the way you can handle it? So I'll just share my video here. So am I audible?
Yes, sir. You are audible.
Addressing anterior posterior, and this is a normal standard technique for any macular hole surgery, and this is just a flap across the membrane but across the hole. But again, with this, even the smaller hole can also have this kind of postoperative non-closure. But when you have a larger hole, it has been seen the inverse flap technique gives a good result for closure of the hole. But once you have done the surgery and you don't have the remaining membrane to ILM to put it over this, so you can get a free flap and then plug it over the failed macular hole area. But yes, this is a technique which we usually follow. But again, this is an ILM which is plugging it there. It is actually plugging the hole, but does it have the retinal tissue per se? So no, we have seen this is a scar tissue by doing this OCT. And then a new idea came to our mind that if we can put, instead of this ILM only, if we can put the full thickness of the retinal graft there and see how the things are happening. So we have designed a special trephine for that, and then started planning with this. This design, this is the macular hole size was measured, and 15% we increase the size of the trephine size is 15%, and choose the trephine. It is already vitrectomized eye, so under this saline we just refine the area. It's just a simple rotation, and it is a double-ended. It has a two guard inside, so it will not cause injury to the choroidal area. And once it is done with the left hand, with the right hand, we did the fluid air exchange, and under air, this graft has been placed very nicely. You can see it there, and then gently tucked by your silicone tip cannula, and the rest of the fluid is being taken out by that. Donor site, you do a thorough laser at the donor site, and then gas has been injected. Now followed by obviously prone position. Now we were very excited to see how was the result was there, and then definitely we got the good result. And you can see the graft was very well placed, and graft is somehow having a similar kind of a architecture of the retina, and this is the stimulus for us to look into it. So now, once the graft has been, anatomically successfully done, this grafting and the hole is closed, then we were looking for this functional ability of that graft. And there are reports that the graft has been survived by different, by doing a fluorescent angiography. We did 10-2, central 10-2, and you can see near about 25 to 27 decibel of this macular threshold, so which is a significantly high amount. These are the initial 7 cases what we have done. This process has been started since 2014, is almost 7 years from now to 6.5 years. And this is this initial, even out of these 7, you can see there are 3 cases which has a significant improvement of the vision, especially the near vision, and the patient is able to read newspaper in those grafted, successfully grafted cases. Now there are different surgeons who are doing this technique as well. for this macular hole, the retinal grafting for the autologous retinal grafting for this macular hole failed macular hole cases. But the technique is little different. In those cases, they usually use a larger size of the macular hole and then they put it over that, which acts as a scaffold. But in our cases, which is totally different, and then we just put the exactly similar size of the macular hole, a similar size of the graft, and with the end-to-end contact. And the hypothesis is that the end-to-end contact between two neural tissue is causing an aberrant regeneration. So that is the reason we have avoided any kind of viscoelastic agent to put it or a liquid perfluorocarbon over that area, or we have not used a silicone oil as well. So if we can compare the functional ability of this graft, so the first one was a normal one, normal macula, and this is a multifocal ERG of a closed macular hole. This is a failed and grafted with the preflap, and this is a retinal grafting. So if you can see the four MFERG at the same plate, this is normal, this is a classic peeling, this is repilling and plugging, and this is our grafting cases. So obviously this is we can see functional and chemical and functional ability of that graft is doing very well. So if we can think of it, this is probably the way forward of it. These are the initial cases of macular grafting, and you can see the three different cases, which you can see it is as a collage here, and we are just putting the graft. You can very well see in all the cases the graft was very well placed. We are placing the graft.
All due respect, sorry to interrupt.
And if you can put this is the unique technique, we can have a larger series, and then we can.
Sorry to interrupt. Sorry. Thank you so much,
Dr. all of you to kind of use this
technique,
and we can
I
have a
would
larger
like to make a crucial announcement among the doctors
Thank you so
right
much.
now.